Good evening, everyone, and welcome to the second Conversation That Matters series. My name is Caroline O'Regan. I work with the Institute of Leadership in the Royal College of Surgeons in Ireland. Tonight, I am very pleased to have the opportunity to talk about ethics in the Covid-19 crisis. This is a complex and sensitive area and is particularly challenging in this pandemic. It is with great pleasure that I wish to welcome our panel of experts. Dr. John Fitzsimons, Consultant Paediatrician, Temple Street Hospital and Clinical Director for Quality Improvement. Ms. Karen Green, Director of Nursing at Beaumont Hospital. And Dr. Miriam Colleran, Consultant in Palliative Medicine, St. Bridget's Hospice and Naas General Hospital, who are joining us here this evening to talk about ethics in its broadest sense. It is timely that we talk about ethics and some of the learnings from other nations, its impact on patient care from a service delivery perspective, and how this is a shared decision-making process, and the changes in the ethical processes that underpin how we have made decisions for care prior to the pandemic. John, Karen, Miriam, it's lovely to see you all. So John, over to you. What's going on right now from a global perspective?
Thanks, Caroline. It's a pleasure to be here, and pleasure to be here with Karen and Miriam as well. It's not surprising, I suppose, that ethics has kind of come to the fore in the current pandemic, and for lots of different reasons. And I think if you look globally, you know, many of the societies internationally, medical councils, governing bodies, professional bodies are all talking about the ethics related to the pandemic. Now, I suppose to think about ethics in its broadest sense, which is just the concepts, the principles, and the values that guide us in determining the behaviors that we adopt. Now, we use ethics all the time, but I suppose in a crisis situation, you know, being clear on what those ethics are is important. Like I said, there's lots of documents out there. Many of those documents kind of relate to, you know, very particular issues around the allocation of ICU, let's say, resources, and the importance of you know, using ethics in that situation. And I think, you know, that in itself is such a particular issue that we have, I think, suggested that we would do a webinar on that specifically on Thursday night, talking around the ethics of decision making with regard to ICU and COVID-19. But I think there's much broader ethical issues as well, and I think it's really about how we use principles and values in deciding the things that we need to do. And I suppose I was struck in reflecting this about, I suppose, the overlap with quality and the ideas around quality and knowing what quality is and how we define that. And indeed, if you look at the roots of the words ethics and quality, they both kind of come from that meaning of the characters of something, the goodness that defines practice. And I think there are so many examples where we have to think about how we meet the standards of goodness in this new paradigm, and whether that's the allocation of resources and the need to kind of change how we allocate resources, and in particular, I suppose, how we allocate staff. Needing to design new systems and really to do that at an alarming pace. You know, we've had to do things that traditionally might have taken months or even years, and we're doing it now in the space of days and weeks. And all of that relies on knowing what our values are and also kind of being able to be flexible. You know, that's one of these I suppose values that comes out in many of the ethical guidance, being able to adapt to the new situation, being able to change the way we work, both with kind of families, and obviously in particular the restrictions that have come through infection control measures, how we can interact with families from the point of view of communicating with them. We spoke last week about practicing in the era of COVID, medicine with all the issues around personal protective equipment. Again, that brings up ethical issues around how we choose to communicate, the things that we can do to, I suppose, compensate for some of the challenges. And I think all of those issues, I think, are things that can be not fully overcome, but I think one of the big issues within ethics is how do you balance priorities? How do you start to compensate and trade off priorities? And it doesn't necessarily mean that you have to relinquish, I think, good values. You can still try and ensure that you are being person-centered. And I mean that from the point of view of being person-centered from the point of view of the patient, but also from the point of view of staff. And I know from talking with Karen, I think some of the work in Beaumont, I think, is very much reflecting, I think, those taking those values into action in terms of trying to kind of adapt to the new paradigm, but holding on to kind of the ethical principles that are important to us. I don't know if Karen wanted to come in there, maybe even to talk a little bit. We were just talking about, we've just seen a nice picture on Twitter of a team all gowned up in PPE, but they've got their names written on their PPE, and they've got photos of themselves, and
fantastic.
Yeah, and I think that's the kind of adaptability that is, I think that there's so many kind of principles there. I think that shows a deep sense of person-centeredness, I think, in care and what people are really thinking. It's so important that I communicate not only with my colleagues, but also with families to show who I am.
And that's a really beautiful point, John, because we talked about PPE and the issues in the lack of communication or the impact on communication. So that's a fantastic example. So thank you for that. Karen.
Yeah, thanks, John. Good to see you're still live on Twitter. I follow you all the time. But yeah, I suppose from my perspective, I think this conversation is really important, and I think it's probably one that we're going to have to tap into kind of fairly frequently, if not in this type of forum, and certainly locally and with our own kind of professional groups. I suppose what I'm seeing is, and I've heard it so many times, is situations like this absolutely bring out the best in people. And I think the example that John refers to, just shows in the face of a situation like this where, staff can be frightened, staff are coming in certainly to the unknown on a daily basis, but they still do everything they can, I suppose, to get that sense of team, because by no means are we operating as we normally would as a team, but they're doing everything they can. And if that's just by putting names or roles onto their PPE, that's really important for each other, for the team, but also, I suppose, for the patients, so that they know who the people are, because we're all kind of nearly blended into a sea of scrubs at the moment. But I think what's overwhelming for me as a director of nursing is that, I suppose, our primary responsibility remains the same, and that's to care for the patients that present themselves to us. But I suppose the balance is that, whilst we're, so focused on providing care for our COVID patients, I suppose the dilemma and the ethical piece of that is, how do we ensure that the essential services that we need to maintain for other groups of patients, that there's no loss or there's no impact, or as minimal an impact as possible for those groupings. So I think, I suppose, for me, you know, it's so ever changing, but the complexity of this requires just such openness and honesty with the staff, and that's essential to look at. And for people, I suppose, like myself in leadership positions, because more so than ever, I think staff are looking at us for that essential guidance, for direction, for support. And I suppose when I was asked to kind of reflect on the ethical dilemmas, it's such a broad topic, but I suppose the most natural way for me to do that was really to look at it on the various different levels, starting with the impact on a personal level, or for us as people. And I suppose it's probably reasonable to say that I'm sure for every single person listening in this evening and that's joined the conversation, that they, you know, including myself, that we've come to work over the past few weeks concerned about elderly parents, concerned about children at home, concerned about the possibility of transmission of a virus from the workplace to home or vice versa. And they're very real concerns. And I suppose, you know, the bit as the director of nursing for me is that we need to listen to those concerns. We need to be mindful of them, and we need to kind of, I suppose, support staff and ourselves through that. And I think then when you take it to the next level on a professional basis, I suppose the dilemma that faces us in that context is our duty to, I suppose, as best as we possibly can, provide for the needs of our patients that are so dependent on our care. So there's a bit of a tension sometimes, and depending on the day that you face, between that kind of personal dilemma of, you know, the impact this is having at home versus that coming on duty and wanting to, you know, operate to the best of your professional duty. I suppose one of the things that's so meaningful to us from a nursing, but I think from a wider healthcare professional, is our approach to care. And I think it's fair to say, in looking at the Department of Health, you know, guidance, the ethical framework, I suppose we're having to shift from a patient-centered practice to a practice that's somewhat kind of guided by the public health considerations, and that's requiring us to, I suppose, adjust pathways of care at a really, really fast pace. And I suppose some of the issues to the forefront of my mind is the huge impact that this is having, firstly on family members that we are so reliant on in terms of care delivery, but with, you know, no visiting policies in place, with very few exemptions, you know, particularly for, you know, end of life care. And this puts a massive strain on us as professionals, I suppose, to ensure that patients are not left feeling isolated or alone at a time actually when our resources is so stretched. So that's something that kind of, you know, I really am working hard to come up with novel approaches to make sure that we don't have patients in a frightened or kind of feeling alone. I suppose I'm also troubled by the hidden impact of COVID. I think it's very easy to come into work on a daily basis, and because of the gravity of the situation and the, you know, the acuity of the patients, to forget about, I suppose, the patients that are not accessing our services at the moment. And that, I suppose, having spent most of my clinical career in the field of neurosurgery, I'm only too aware of all of the patients, you know, kind of nationally that are so dependent. And whilst we continue to, of course, bring in our emergent work, there's so many patients on waiting lists that we also need to I suppose, make sure that we're really working proactively to change and amend pathways of care. Now, I think, I suppose, one of the other pieces, and I don't want to, you know, hog all the time, but I'm also really cognizant of our colleagues within our local catchment area, and particularly, I suppose, those I'm referring to is some of our my colleagues within nursing homes that are, you know, we're used to working with all of the time. And, you know, it's really important to make sure that, I suppose, our most vulnerable cohort of patients are protected and minded and cared for throughout this, you know, unprecedented situation. So I suppose I'm really making a conscious effort to tap into the directors of nursing and colleagues within our local nursing homes to make sure that we're working together to come up with solutions that are appropriate to make sure patients are receiving timely care. I know, I suppose, the whole issue of kind of resource allocation is something that is getting a lot of attention. But I think, resource allocation is one piece of it, but I'm also really conscious of the whole kind of accelerated learning environment that we're having to operate in. So I suppose staff norms are really no longer the norm, and I think the impact of teams and on managers in, I suppose, providing that clinical supervision, providing, I suppose, those accelerated pathways and clinical learning environments is something that I'm very cognizant of, and that can be really stressful for staff. So the outside environment is stressful, but also I suppose that the daily situation of working in different locations, maybe being asked to do different roles, and actually asked to kind of embrace different learning opportunities. That's all, but I suppose they're the issues that face us. But one of the really important pieces of this for me has been that, I suppose, in terms of solutions, I'm really overwhelmed by, I suppose, the power of the clinician and nursing relationship in coming up with solutions. We're meeting so regularly, we're having very eloquent socially distant huddles to make sure that at various time points through every single day we're touching base, we're considering the needs of the organization, and that's patients on the COVID pathway or patients outside of that, and we're all working really, really well together to make sure that that clinician, nursing, health and social care professional relationship, and all with the greater good of caring for the patients that are in front of us, but also being really mindful of the patients who are maybe waiting to access our service also.
And Karen, do you find that that is QI helpful to you at all there in terms of, I think it's a good way in many ways of taking new ideas and testing them and trying them out, and aside from obviously all of the goodwill and the principles kind of that people bring, but I think there are methods that can help people as well to adapt.
Yeah, I think probably people are not giving themselves the time to call it QI, John, but having certainly somebody who uses QI methodology all the time in delivery of my role, I think people are doing it every single day by taking novel approaches, starting small scale, testing it out, looking at impact, and and we've a really good QI team here to support and guide people through that. But I think they're just not taking the time to label it at the moment, but it's happening all the time organically.
Karen, thank you so much, and I'm just conscious to get some questions in from our listeners. I'd like to just pass over to Miriam, who'd like to talk in terms of the impact, as we discussed earlier on, in relation to the families and the patients and the impact of the.
Thanks very much, Caroline. I suppose first, we all recognise that this is an evolving and rapidly changing area. What we're discussing tonight is what we know today, and tomorrow things may change and we may have to revisit these issues again. As we've discussed before, Caroline, ourselves, we need to be responsive to the issues that are arising in clinical practice. From a palliative care perspective, there are 3 issues in particular that I would like to highlight today, namely the care of the patient who is imminently dying, supporting the families of ill or dying patients, and also bereaved families, and lastly, the impact on staff of this changed practice. As we know, there has been quite a bit of discussion about people with underlying medical conditions and the elderly, as they are more likely to be at risk from coronavirus. But ultimately, a person with an underlying condition or an elderly person is a person, just like the rest of us. A person with hopes and dreams and loves, and a person that usually has people who love them too. They are an intrinsic and an important part of our community, and we want to mind them, just as Karen was saying. If a person's life is going to be shortened because of COVID-19, that's sad. And we want their dying to be peaceful, natural, and appropriate. Dame Cecily Saunders was the founder of the modern hospice and palliative care movement in the UK and Ireland. She said, "You matter because you are you, and you matter to the last moment of your life. We will do all we can, not only to help you die peacefully, but also to live until you die." Dr. Catherine Mannix talks about patients who are sick enough to die. So say 2 months ago, Caroline, if we were chatting, if a patient was ill and sick enough to die, if a patient was expected to have a natural and anticipated death due to advanced illness, now whether that patient was in hospital, at home, in a hospice, a nursing home, at home in the community, there would most likely have been a plan of care for symptom control for that patient, and that will still happen as much as possible. But also, and very importantly, there was a practice of inclusiveness of the patient's family or loved ones, if that was the patient's wishes, what Karen was referring to too. So family got to spend a lot of time with dying patients who were in a healthcare institution. That was our practice. We had a practice of compassionate, patient-focused medical care. And there was a big emphasis on communication with the family. Secondly, we know that if a patient's family feels that their deceased loved one was well cared for, and if they feel that they themselves as family members were listened to, it helps their own bereavement process, which is really important. Now, however, visiting is by necessity dramatically decreased, so patients can be experiencing loneliness. And family have the upset of knowing that, and also the possible distress of being apart from them. And there's also less in-person therapeutic dialogue with families and more phone or virtual communication. It can be helpful. It can definitely be helpful, but it's not the same. So this is an ethical issue for us too, and how do we diversify our practice? And then lastly, and again echoing what Karen was saying, pandemic medicine impacts on staff. As Dr. Ira Byock said, this pandemic is personal. And this pandemic is personal in many ways. It's personal because we too could contract COVID-19, but it's also personal ethically. We have great healthcare staff. Providing supportive end-of-life care is really important for us, and it is very difficult for staff to be so stretched and to have less direct face-to-face time with patients and families, and to have to communicate with families more by phone or virtually, as I mentioned before. It's not the same as communicating in person and giving a gentle or encouraging smile or a handshake, or maybe just a pat on the shoulder. It's not the same. So it's the diverse issues of optimizing infection control measures and helping prevent the spread of COVID, which is essential, but also providing that compassionate, patient-focused care and support for families. We're practicing differently, and it's challenging us in many ways, including ethically.
Yes, thank you so much for that, Miriam, Karen, and John. So I'm actually going to pass over to my colleague Tina, who has been taking the questions coming in from our viewers and audience this evening. And Tina will come in with some questions for the panel.
Thank you very much, Caroline and Miriam, Karen and John, for that really interesting piece on ethics. There's a question in here from Emma, and Emma is working in the ED department, and she's paying tribute to what you're saying and the pathways and all of that. But she's kind of saying, what should we be thinking about now in terms of how people are going to handle this in the future? Because everybody's in the thick of this at the moment, and they're making decisions. But should we be thinking about the future and the impact that some of these decisions and these consequences that we're having for people at the moment? Could I throw that back to the panel, just in terms of your own thinking on that?
Who'd like to take that?
I might just respond to that. First, I think we will need to think about the future. We will need to do things in the future. I think we will need to provide what people need I'm not sure if we know exactly what that is yet. I think there will be probably different people will need different things, and I know there is a mobilization, I would say, at this stage from psychology services, from the colleges, from the HSE, from the hospitals, of people who are coming forth, to offer their abilities in terms of helping people deal with some of the processing and dealing with the emotional impact and the psychological impact of this work. I think the major focus at the moment, though, needs to be on the present, and I suppose helping teams as much as possible to deal with the situation that they find themselves in, whether it's like Miriam was talking about, the new situations around dying and the difficulties for families, and therefore the roles staff are needing to take to help at that point. So I think the major focus for now is now, but I think it will be a big challenge to make sure that we do give people access to appropriate resources in the future.
And I'll just jump in there for a moment, if that's okay. I think that, thanks very much, Caroline. I think there's a few aspects to this, because we're learning exactly as John has alluded to, but we're learning about how to communicate differently. We're learning, and I would have to say we have a lot of, in palliative care, our community palliative care team nurses would be very used to giving a lot of phone support to patients and families. But for others like myself, this is actually something that we're less familiar with doing over the phone. We're more used to doing it in person. But there's actually a lot of really good guidance out there, a lot of really good evidence and literature, and I think we're going to be discussing that at another conversation that matters, Caroline and Tina, isn't that right? Yeah. And then what John was alluding to, and I expected to, that Emma was asking, was about supports for staff. There is a lot of evidence that there needs to be a lot of caution in terms of how this is done, because that we don't actually want to negatively affect people's natural coping. Most healthcare staff are very resilient, and that we don't want to adversely affect that, and that there's actually that actually needs to be a means in how it's done. And the evidence coming out from China shows that what Chinese doctors needed was rest, PPE, get sleep, eat healthily, that in the immediate crisis, that's actually what the clinical staff needed. But we are, I think, having that as another discussion, another conversation that matters about caring for the healthcare teams.
Thank you for that, Miriam. Karen, did you want to come in there?
Yeah, I suppose it's just like, I would agree with John that it's very hard to put yourself into kind of a future state right at the minute. But I think it just to wrap that up, what we really need to make sure we don't lose sight of is there has been some, hugely novel approaches to looking at care in different ways. There's some been really good use of technology in the whole care arena. And actually we have, as I said, we've accelerated the learning environment. So actually we've opened up a whole new skill set to a lot of our staff throughout. So I think we need to also in time make sure that we take the good from this and use that in our future practice.
Caroline, Caroline, there's another question in relation to the whole looking at the document that was published recently from the Department of Health and Critical Care. And I know we're going to talk about this further on Thursday, but there is the person here, Marianne, is writing in to say that she has concerns, or what do you see as the concerns around human rights and ethical implications that document brings to light? Yeah.
Thank you, Tina. And I think that's a really good question. And I think we have set aside a conversation specifically to address that document and some of the policy documents that have been developed by some clinicians around the country, which brings us nicely into the end of this session. We will be meeting with those colleagues on a panel discussion on Thursday, and they will be talking specifically to ICU resources in terms of decision making and standards of practice specifically in relation to guidelines that have been developed aligned to the Department of Health. So we'll have more time to talk to that on Thursday. So I suppose in way of finishing up, I'd like to thank my panel very much. Thank you to Karen, thank you to Miriam, thank you to John. Some of the takeaways that we have from this evening's discussion, patients whose lives are sadly shortened by COVID-19, we want them to die peacefully, naturally and appropriately. From an ethical perspective in service delivery, shared decision making is absolutely where it's at. All clinicians and health staff are now in a room together, making that collective decision, demonstrating collaborative leadership. And really importantly, from a service delivery point of view, using good, sound professional judgment. There are no guidelines in the waters we are wading in at the moment. And from John's perspective, we're looking at values in action and not losing sight of ethics. And that brings us to the end of today's session. And on Thursday at 6:30, we will be joined by Dr. John Bates and Dr. Emer Ahern. Also, we'll have the privilege of having Dr. John Fitzsimons and also Dr. Miriam Colleran back with us on the panel to further this discussion in much more depth. So I'd like to thank all our listeners and just to remind you that additional supports are available through a series of video links by Professor Michael West, Senior Visiting Fellow from the King's Fund and Organisational Psychology at Lancaster University. There is a free webinar tomorrow evening at 8 o'clock or 4 o'clock, sorry, 4 to 5, available for health and well-being of the healthcare staff during COVID-19. And any suggestions for future conversations, if you wouldn't mind emailing RCSI leadership@rcsi.com. So thank you so much to our panel again, and to our listeners, and all of the people who helped make tonight happen. So good night and thank you all.
Thank you.
Thank you.
Thank you.